This is Dr. Seth Gamrad from USC talking about the differential diagnosis for knee and shoulder problems. This is a very short presentation that's intended for medical students, residents, young faculty in organizing how they approach knee patients and shoulder patients in clinic. So first of all, when a new knee patient comes in, I like to know their age. I like to ask them where their pain is, how long they've had it, and is there a history of trauma. The location of their pain narrows the differential diagnosis significantly. If the pain is in front, then the differential diagnosis oftentimes includes patellofemoral instability and patellofemoral pain. If the pain is truly tibiofemoral joint line pain, then you're talking about meniscus, cartilage, arthritis. Ligamentous instability patients, in all likelihood, are going to have a history of trauma, a discrete event that caused the problem, and they'll have physical exam findings to support that. For example, an ACL tear will come in with a history of usually a non-contact or contact injury playing sports with a pop and swelling. Multi-ligament knee injuries will come in with a history of a severe trauma such as an ATV accident or automobile accident. And then there are certain problems which aren't really knee joint problems at all because their symptoms are proximal or distal to the joint line and often related to overuse, such as pes anserine bursitis, iliotibial band syndrome, etc. So when someone comes in with patellofemoral instability in my office, if it's an acute dislocation, I treat them with a brace and rehabilitation unless they have a loose body or a chondral injury, and then in that group, they'll get early arthroscopy alone. In chronic cases where they've had repetitive dislocation of the patella, these fall into two main groups, with a high Q angle and a high tibiotubercle to trochlear groove distance. A tibial tubercle transfer can be effective. With just simple medial soft tissue laxity or insufficiency, an MPFL reconstruction can be performed. Trochleoplasty is also performed for people with shallow trochlear grooves. In patients with patellofemoral pain, this is a difficult group that's been called the low back pain of sports medicine. Patellofemoral pain syndrome truly exists, PFPS. This is a person with normal articular cartilage without MRI evidence of any damage, but they still have significant patellofemoral pain. These patients often respond to physical therapy and oral anti-inflammatories, very occasionally an injection. The chondromalacia patient or chondral injury or osteoarthritis oftentimes is treated the same way, physical therapy and injections, but there are cartilage restoration procedures that can be done here, lateral releases if the problem is predominantly tight lateral retinaculum and lateral overload, and occasionally a tibial tubercle transfer can be performed in this group as well. If there's tibiofemoral or joint line pain and the x-ray is normal, oftentimes the MRI is going to help you out a lot. It's going to show you meniscus and cartilage problems. Meniscus trouble is treated with partial meniscectomy or meniscal repair if the tear is amenable. Cartilage restoration can be microfracture, autograft oats, allograft oats, or autologous chondrocyte implantation. In osteoarthritic patients, their radiographs are abnormal. They'll have joint space narrowing, subchondral sclerosis, cyst formation, and osteophyte formation. In these patients, I go through a mental checklist and try to figure out what they have not tried among the things in my armamentarium for osteoarthritis, such as nonsteroidal anti-inflammatories. I like Celebrex, physical therapy, activity modification, bracing, viscosupplementation, and in older folks, a cane or a walker can be helpful. In these patients, obviously, you're looking for more invasive procedures if you're going to solve their problems, such as correctional osteotomies, unicompartmental knee replacements, or the granddaddy of them all, a total knee replacement. Now, if someone has a true ligamentous instability from trauma, this is usually in my practice going to be surgery in all but the least active patients. An ACL tear is going to have a Lockman test, anterior drawer, pivot shift. PCL is going to have a posterior drawer positive. Posterolateral corners will have varus at uh, full extension and 30 degrees, especially when combined with a cruciate ligament. In addition, these patients will have increased external rotation laxity at both 30 and 90 degrees when combined with the PCL. MCL injuries are tested in valgus stress at 0 and 30 degrees. Combined injuries will open at full extension. So that's my approach to knee. That covers most of my practice in knee. The shoulder is a little bit different. We like to divide these groups in based on age in my clinic. Young patients, they're very active. The main problem in young patients is going to be instability, labrum tears, throwers, fractures, and AC separations because they're very active, falling down off motorbikes and mountain bikes, etc. Middle-aged patients become more sedentary and get impingement, tendonitis, and frozen shoulder. And older patients will get more degenerative conditions such as rotator cuff tear, osteoarthritis, cuff tear arthropathy, and then they get a second set of fractures, not because they're wild and crazy, but because they're osteoporotic. We usually see proximal humerus fractures in this group. So I like to tailor my physical exam based on this differential diagnosis. It helps me get out of the clinic a little bit faster, helps me make the diagnosis without putting the patient through an entire battery of 1,000 million tests. So in the young patient, I want to know their motion, their strength, and this is where the instability and provocative tests can be really important, such as apprehension relocation, load and shift test, jerk test, O'Brien's test, etc. Middle-aged patients, again, I want to check their motion and the strength. Since impingement is very common, I want to check their Neer and Hawkins, and palpating the patient is very important in this group. I want to see their AC joint, their biceps to really pick up on where their pain is. Older patients, the physical exams, pathognomonic for most of these conditions. Rotator cuff tears will show decreased active range of motion and weakness in the muscle that's torn. Osteoarthritic patients are actually stiff. They'll have decreased range of motion, and you can't really force them past that range of motion because their active range of motion equals their passive range of motion. They're really going to only have strength loss related to pain only. Cuff tear arthropathy patients will have dramatic differences in their active range of motion, but oftentimes their passive range of motion is pretty good because their cuff's gone, they're not very stiff. These patients will be very weak, they can have extra rotation lag, and they can have a hornblower sign. So in these young patients that are unstable, anteriorly they'll have a positive apprehension and relocation sign, especially in abduction external rotation. And this is the mnemonic. Traumatic unidirectional Bankart lesion usually requires surgery, TUBS. We'll do an arthroscopic Bankart repair. If someone's had a ton of dislocations, we'll suspect bone loss, and we can start thinking about a Latarjet. Multidirectional instability, that's the mnemonic AMBRI. Atraumatic, multidirectional, bilateral, usually responds to rehabilitation and infrequently requires surgery. I suspect multidirectional instability in young patients, especially female, with hyperexternal rotation. These patients can be able to go to 90 or 95 degrees at their side, and they can abduct their shoulder past 180. In addition, they'll oftentimes have a sulcus sign, which is gentle traction longitudinally with the arm in adduction. These patients, we really treat them with physical therapy for at least 6 months. If that doesn't work, then I'll do an arthroscopic capsular plication. In my hands, that's 2 anchors in the front, 1 anchor in the back. Posterior instability, if it's truly dislocated and stuck out the back, the patient has likely had one of the 3 E's. That means electricity, like a lightning strike or a shock, epilepsy, like a seizure, or a high energy motor vehicle or motorcycle trauma. Most of the posterior instability patients that I treat are athletes that present with recurrent posterior subluxation alone. These are football linemen who have trouble in adduction and interrotation, and these patients respond really well to arthroscopic posterior labral repair in the off season. In patients without instability but signs of a labral tear, oftentimes these are your SLAP patients. They'll have chronic pain from lifting or trauma, and we diagnose those with an MRI arthrogram. The throwers is a whole separate animal. They tend to have glenohumeral internal rotation deficit, meaning they gain some abduction external rotation but lose abduction internal rotation, placing them at risk for superior labral tears and partial thickness rotator cuff tears on the undersurface. And again, these young patients will have fractures and AC separations, which are treated injury by injury based on the severity. Middle-aged patients, this represents a lot of my practice actually. 35 to 55 or even 60-year-old patients in the absence of trauma. All of a sudden, their shoulder starts hurting. This can fall into impingement, that's a positive Neer and Hawkins, rotator cuff tendonitis, that can be rotator cuff or biceps tendonitis. Oftentimes, these impingement patients or tendonitis, we'll treat them with injection, physical therapy, oral anti-inflammatories. Rarely, we treat them with an isolated subacromial decompression. Typically, in my hands, these are the type 2 or type 3 acromion patients that have trouble improving their problem with physical therapy. If someone has a true rotator cuff tear in this group, they oftentimes have a history of trauma. They were at the ski resort, fell down, now they've had weakness for a few weeks, take an MRI. In this young age group, if they have a full thickness tear, these go right to surgery. We repair those full thickness tears. Interesting group is frozen shoulder. The medical terminology for that is adhesive capsulitis. These are usually females, 40 to 60. Risk factors are diabetes and hypothyroid. If I have a female with atraumatic shoulder pain, I think the likelihood that they have an adhesive capsulitis in some stage is greater than 50%. I always ask the resident and fellow when they come out of the room, is the patient stiff? And they say, no, they're not too stiff. But then when you really check these shoulders in detail and their range of motion, they're oftentimes really limited, and that's the true culprit of their pain. So I grade these on cause, stage 1 through 4, and level of irritability. I'll treat these with 2 cortisone injections spaced 6 to 12 weeks apart, as well as physical therapy. Oftentimes you can get them better 8 or 9 times out of 10 without surgery. But if this doesn't work, we'll do an arthroscopic capsular release. And last slide here in my talk is the older folks. Older folks, again, they have degenerative conditions. If an older patient has had an acute trauma and they went from having a strong shoulder to a really bad weak shoulder and take an MRI and there's an acute tear, I'll take them straight to surgery. With chronic tears in older people that are small, I'll treat like impingement. I'll inject and rehab them because I think the natural history of this group, especially in the 70 and up set, is pretty good. If they're younger, symptomatic, full thickness tears, we'll do an arthroscopic repair, especially if they've failed a little bit of conservative treatment. Osteoarthritis with an intact cuff. For me, again, it's like osteoarthritis of the knee. Rest, injection, anti-inflammatories, activity modification. If none of these work and the pain is running their life, then it's an anatomic total shoulder replacement. Cuff tear arthropathy, we treat with injection, physical therapy with anterior deltoid reeducation and strengthening as per Ofer Levy in England. If that doesn't work, that would be a patient who gets a reverse total shoulder replacement. And then fractures of the proximal humerus in the elderly, I think, fall into four groups. Minimally displaced, we all know what to do with them. Put them in a sling 2 to 4 weeks. Once they start making a little callus, gentle physical therapy, close x-ray follow-up to make sure you're not going too fast. If the fracture is displaced with good bone, not too bad of comminution, that's an open reduction internal fixation with the locking plate. If the fracture is dusted with severe comminution and osteoporosis, that'll be a hemiarthroplasty, but more commonly these days we're going with the reverse. And then there's lastly a very interesting group, which is a displaced sort of nursing home player that is unfit for surgery. It's interesting. We treat these conservatively oftentimes, but they oftentimes end up being a significant source of disability. So that concludes my presentation. This is kind of an overview of a lot of the knee and shoulder in my practice. Obviously, there's some things that are going to fall outside these niches. This is the framework that I approach knee and shoulder patients in the clinic, and I hope it helps in your clinic as well. Thank you very much.